Good afternoon, everyone. Thank you for such a lovely introduction. And before I get started, I want to introduce someone from our group, Natalie Helmers, who's hiding back here. She's our nurse practitioner, specialist nurse practitioner in Parkinson's disease. So I brought her along to help me with the question and answer sessions. And as you'll see, as we go through the slides, she's been very much an active participant in building this body of work and this body of research that I'm going to really just give you a little bit of flavor of. So just before I get started, I'm not going to give you a review about Parkinson's disease. I want to talk about some of the areas where we feel we could do better and some of the areas where there's some really, really interesting research going on, and I think a lot of hope for improvement in the future. So a little bit of background, and you'll see I've headed this the traditional view, so you can guess we're not going to be taking a very traditional view of Parkinson's in the rest of this talk. But really, Parkinson's disease, when it was first described, it was 1817, described by James Parkinson. And he described very, very nicely the movement problems that people have that you'll see right up here. And let me see if I can get this yet, but it works. So there's problems with movement, problems with coordination. People feel stiff. They may feel like their muscles are cramping, and people slow down. And as time goes by, it really becomes more difficult to handle those symptoms. And we have a lot of medications that can help with that. We do have treatments that I'm going to touch on. So this is the traditional view that what those symptoms of stiffness and slowing, etc., are coming from is a pretty simple decline in the amount of a particular chemical called dopamine that's made in a very, very tiny area of the brain. This is someone who doesn't have Parkinson's, and it's a little, I hope everyone's had a good lunch, because I'm going to show you some anatomical specimens. But this is a little tiny area of the midbrain. It's sort of between what you think of as the brain, the hemispheres, and between there and the spinal cord. And there are two kind of stripes of cells that go a little way along the length of this area of brain. You see they're colored black here. They make dopamine. And these are the cells that are not functioning as well as they should in Parkinson's. So really what happens in Parkinson's is these cells are damaged. They don't make as much dopamine as they should make. And so because you need dopamine for good coordination, good movement control, that's actually what gets affected more than anything else. And this is the same area, little tiny portion of brain right here in someone who has Parkinson's. And you can see with the naked eye, actually, when you look at these specimens, that there are not those same dark cells. Those have disappeared. So there's enough loss, you can actually see it when you look at these brain specimens. Well, that's the traditional way of looking at things that most of the treatments right now are based upon. And that is, if you lose dopamine, okay, replace it. And that's what most of the medications that we have are designed to do. But I want to show you some challenges now in terms of Parkinson's treatment and just show you why that's not good enough and how we need to make things a little bit better. So in terms of current ideas about what's affected in the brain in Parkinson's, this is a lovely study that came from a pathologist called Heiko Brack. And he's very famous, actually, even before he moved into Parkinson's research. He's very well known for his work on Alzheimer's disease and figuring out what different parts of the brain Alzheimer's affected and how it might spread. Well, he did the same sort of approach for Parkinson's disease. And what he figured out is that it's very likely that those cells I just showed you that make dopamine are not actually the place where Parkinson's starts. And it can really start outside of that area. And what you can see right here, I hope, is, all right, it's conked out already. I'll show you. Can you still hear me?
Yeah.
Okay, just right here, down at the bottom of the left-hand panel, you'll see where he thinks Parkinson's starts. And actually what happens over time is it spreads slowly, a little bit more upwards in the brain, until it comes right up here. And that middle panel shows you what's affected when you start to get movement problems. And then after that, it can spread a little more. So you get movement problems, but then you can have different movement problems that come from damage and Parkinson's effects outside of that little set of cells that I showed you. And so this is great science, but actually the bottom line is that the drugs that we've designed to help Parkinson's that all work on dopamine won't work for a lot of these other areas of brain that are affected. It's why they don't work so well for balance. They don't work so well for people who have speech problems with their Parkinson's. And if people get insomnia and sleep disruption that comes from a different part of the brain being affected by Parkinson's, our dopamine medicines don't work so well for that. So, thank you. So actually you can see Parkinson's disease, it's a complex array of symptoms. It's not just movement, it's sleep, it's mood, it's visual processing, all sorts of things. And what the nice thing about this model is that we can actually pinpoint different areas of the brain that are affected. And so this recent advance in understanding how Parkinson's affects different areas of the brain now gives us a very, very different idea of the sorts of medicines or the sorts of treatments that we might be able to look at. So the treatment challenges I just touched on, we have to look at an array of symptoms, and on the left side I listed what we traditionally think about as Parkinson's, the tremor, people feeling weak, muscle stiffness, slowing down. But on the right side, all of these things that come from other areas of the brain that are different from that little tiny area I showed you in the first slide. Things like constipation. Parkinson's affects the nerves going down to the bowels. Hypersomnia, people feeling too sleepy in the day. Orthostatic hypotension, that's getting dizzy when you stand up. So you can see how complicated it gets, and it's really reflected in the number of medicines that we have on offer to treat Parkinson's disease. But before I get into the treatments and what's needed and some of those challenges, I just want to look at some of the other things that we have to think about. When do you start treatment? So that has to do with when you get diagnosed. Once you're diagnosed by your physician, should you really start treatment straight away? Or should you wait a while? When I trained, we were taught you should wait a little bit, and for the strongest medicines in particular, that you shouldn't take them straight away because you develop complications and side effects down the line in the intermediate and the long term over a period of years, basically. So that's been the traditional argument that we've had recently. But I just want to highlight this last point right here, because just recently we've started to talk about not treating once people have symptoms, but treating before people develop symptoms. And that's actually where it starts to get really, really interesting. Because if you could identify someone who's developing Parkinson's, but you haven't gotten to the diagnosis yet, maybe the movement symptoms haven't quite come out to the degree where you can make a diagnosis where you're sure what's going on. But if you could treat before, what if you had treatments that would slow down development? You could actually prevent Parkinson's. I'd be out of a job. I would go to the beach every day. But seriously, this is actually one major area of research that I'm going to talk about. How could we diagnose who's at risk of Parkinson's and where we might start to want intervening with a preventive therapy? The second part of the challenge that I've put here is what medicines are best at which stages. And that also means, you know, when does it happen that the medicines are not working well enough? And when should you start thinking about surgery for Parkinson's? So I'm going to talk a little bit about the surgeries and how those are changing, and what sort of surgical procedures are available right now, and where are we looking down the line, basically. So that was all a little bit of background. I want to take a step back now. You remember I said, wouldn't it be amazing if we could diagnose people who were at high risk of Parkinson's and start treating before it kicks in and somehow prevent the onset of Parkinson's? Well, there's a challenge. Our diagnosis in the office, you know, because Parkinson's comes on very gradually and a lot of the symptoms overlap with other disorders. So it means that doctors, I hate to say this, that we're slightly less than perfect. But there's a recent study actually that made everyone prick up their ears in our research community. And a doctor called Chuck Adler, who's out in Arizona, he actually went back to people who'd been identified with Parkinson's, diagnosed with Parkinson's in their lifetime. And these people had all donated their brains to a brain research bank. And he looked at the brains and he said, well, out of these who had the diagnosis, who really had it? You know, when you look at the brain, how many can we prove that that was actually the case? And he showed that the physicians could identify 88% of people who had Parkinson's, but they got it wrong in a significant number of cases. And there were also people who were identified with other disorders where they were told that they had Parkinson's. Now remember, I was saying, wouldn't it be great if we diagnose people before they get the symptoms? But here we're showing we're not doing a fantastic job even once people get the symptoms. And for any of you who've been touched by Parkinson's or know someone who's had Parkinson's, you may have heard of people being bounced around between doctors, being told you're depressed, or it's an orthopedic problem, or you have a nerve disorder, but not being told it's Parkinson's. So over the last decade or so, maybe a little bit longer, there's been this idea about the need for biomarkers. Now, what is a biomarker? A biomarker is a pretty simple concept. It's a test that you could give that would either show you on a scan, or in a blood test, or a urine test, or a saliva test, or even a spinal fluid test, that someone has a particular disorder. So for any of the gentlemen here who've ever had their PSA tested, PSA is a biomarker. When we look at tracking cancers by using imaging, either ultrasound or MRI, that's a biomarker. It lets you see something that's there that you wouldn't know from looking from the outside, and it helps you track what's going on with it. Well, just over the last few years, in fact, in 2011, we got access in the United States to our first Parkinson's biomarker. So it's really just 5 years ago. So you can see there have been some big changes since I trained. It's a brain scan. It's called the Dat Scan. We have it here at Weill Cornell. The Dat Scan is really great. It takes a half a day. It can tell you whether you've got Parkinson's or something related to Parkinson's or not. It's not 100% accurate, but it's not far from. And I just show you here, we're trying to improve on that actually. And a lot of groups around the world are doing what we're doing, which is saying, well, brain scan, it's something that we're very keen on developing, a highly accurate brain scan that could show us what's going on in the brain of someone who has Parkinson's, how much have they been affected, and we could even track them year by year so that we could say, hey, look, you know, the treatment you're getting now, this is really great, things are not really progressing. Or we could say, hey, you know, the progression, this is not good, we need to do something here. And this just shows you a picture from my colleagues. This was Dr. Mosley, but I should also acknowledge Dr. Yona Kang, John Babbage, who've helped us to set up a way of scanning the brain using a tracer. It's a little radioactive tracer that gets injected. It flies up to the brain through the blood, and it binds onto where these cells are releasing dopamine in the brain. So these are the cells that I showed you right at the beginning are getting affected by Parkinson's. So this is someone who doesn't have Parkinson's. And do you see how this looks like a tadpole? And it's got a head and it's got a tail. So that's someone who doesn't have Parkinson's. This is one of my patients who does have Parkinson's. And we scanned him, and he's had Parkinson's for about 8 years now. And you can see how the dopamine, it's not there as much as it should be. And that's why he's got coordination problems, but we treat him with the medicines that replace dopamine. So these types of scans are great. I should say, though, they may not be ideal. You've got to be near a big academic center to get this kind of thing. It's expensive. And so for us in Manhattan, we're all okay. But if you're in a place that's a little farther out, it's hard to get this kind of thing. So what everyone is looking for right now is, could you develop a blood test, a spinal fluid test, a urine test? And one of the really amazing things about this field of Parkinson's research is that there's a lot of collaboration. There are a lot of groups who are working together. We compete because we all want to beat the others, but we do work together. And I just want to show you, this is a map of the United States right here. And this is a group that the Michael J. Fox Foundation put together. It's a big collaborative group. We've got people out in Seattle. We've got people, a little concentration in New York, of course there always is. But you can see how different groups across the United States, most of us hadn't worked with each other before, we've all come together to recruit people with Parkinson's disease and healthy volunteers who we will happily pull into this type of study to get blood, to get spinal fluid, to ask them lots of questions about their health status. And these samples that we've collected are now all together in a big biobank that's run by the NIH down in Maryland. And they're available to researchers all over the world. And all researchers have to do is to convince a review panel that comprises a lot of experts in the field that what they're going to do is worthwhile. And so this is really moving the field ahead. And we've seen just over the last 2 or 3 years a lot of publications coming out, not with proven tests, but with ideas for tests, using a lot of new technologies. So that's been something really gratifying to see. And what everyone is thinking about as we're diagnosing people with Parkinson's and working on getting these tests to give us a more accurate diagnosis, could this also help us earlier? And I just wanted to bring up this idea of the Parkinson's prodrome. So remember I said if we could identify people who are at risk of Parkinson's disease before it actually kicks in, before they've got the symptoms, we could try doing preventive therapy there. Well, this is the prodrome. What it seems like right now is people who've got a particular sleep disorder are at higher risk of Parkinson's. People who've got loss of sense of smell are at higher risk of Parkinson's. So a lot of the research that's going on now that we think is going to help us with Parkinson's in the future actually is focused on these people who are not yet diagnosed with Parkinson's. So we're really managing to get people in the super, super early stages and then watch what develops and see how we can intervene. I'm going to come back to some of people's favorite ideas for trying to prevent Parkinson's in a little bit. If we could identify people at risk, we could use preventive measures. I just put up one very simple, quite isolated example here. We know that people who are exposed to particular pesticides and herbicides are actually at higher risk of Parkinson's. But you know what? In a study who looked at some farmers who were exposed, if they just did a simple thing of wearing personal protective equipment, their risk went down. So that's not something that applies to the majority of people with Parkinson's, but it's just an example of the ways that we're thinking right now. And there was a recent report again from England, and I just put this up because they studied 8,000 people with Parkinson's, and then they studied almost 47,000 people who didn't have Parkinson's. And again, they're finding all of these things like constipation, or what else, bladder problems, balance impairments that are coming up before the diagnosis. So taking all of these things together, we're hoping that we're going to be able to get some guidelines about diagnosing earlier. So with that background right there, and what we like to aim for, which is basically diagnosing early, preventive treatment, helping the symptoms, not just the dopamine-dependent symptoms, but the others, and maybe reversing, and we'll come back to the reversal later. I want to just give a very quick summary of where we stand right now, and then let's talk about some of the real interesting things that people are looking at that are in the pipeline. So the background of medical treatment, and I'm going to thank Natalie for a lot of these slides actually, but this is the problem. For anyone with Parkinson's, it is pills, 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 pills. People don't like taking pills, tough. It's Parkinson's, this is the mainstay of treatment. And remember I said that what we're looking at in Parkinson's traditionally is that loss of a particular chemical called dopamine. And we want to replace that. And actually, pretty well everything, with the exception of one drug here, everything down here is either replacing dopamine or it's mimicking dopamine. So that's like a whole array of drugs. The non-motor, the non-movement symptoms that people get, like blood pressure problems, like sleep problems, bladder problems, they all need other treatments. So just to show you how many different treatments we're looking at right now, for this thing called orthostatic hypotension, it's if you get dizzy, if you stand up very quickly, if it's bad enough that you need medicines for it, we've got 3 medications that are on the market. So you can see very easily that when you've got Parkinson's, because we're treating the symptoms and we're not trying to reverse or stop the underlying cause, very quickly start looking at a whole slew of medications. And that gets hard to handle. And one of the things that Natalie, our specialist nurse practitioner, has been working on with our patients is helping them to tweak the schedule, get a nice individualized medication schedule. But a lot of that is trying to understand where the medicine's working, where it's not working, where we can do better. And as well as all of those many different medicines that I showed you, so people are dealing with a lot of complexity, but we're dealing with complex medicine schedules because some of these drugs don't last more than a few hours. So again, what we'd really love to get away from in the field is away from just disguising, if you like, the symptoms by giving a medication that replaces dopamine. Before we get there, I have to say that there's a lot of really great research going on. Remember I said that some of these drugs, they don't last that long. Carbidopa, levodopa sometimes might last 2 hours, 3 hours. I mean, you get tied to taking pills over and over again, multiple times in the day. So a lot of the new research right now is actually looking at how could we give someone a dopamine replacement drug like levodopa, but not through taking pills over and over again. Could it be infused? Could it go into a patch pump? And actually there's one company who are looking at could you inhale it? So there are all these different ways that help with the problems that people get from taking that medicine. So just before I switch tack, I do want to say that as well as the dopamine replacing drugs, there are a number of medications that are getting looked at to treat the movement disorder part of Parkinson's disease. They're new, they're not dopamine based, they look at other chemical systems in the brain, but we don't have a whole day, so I'm not going to talk about those. But if you want to bring that up in the Q&A session at the end, I think that would be great. So I do want to talk about the surgical therapies because as well as in my group, we're neurologists, and so really a lot of what we're doing is counseling and education and looking at the best medications that are going to help people with their Parkinson's disease. But we have a fantastic neurosurgical program here, and for anyone who wants to look up what's going on, Michael Kaplan is my colleague and collaborator in neurosurgery, and he's our deep brain stimulation expert. And it's easier actually, rather than scribbling this down, you can Google Mike Kaplan and you'll find him and his work very easily. But he's going to show up again in a second, so I just want to highlight that. In the past, when people started using surgical therapy for Parkinson's disease, what they would do was kind of try to make little lesions. They would try to take parts of the brain that were very clearly hyperactive in Parkinson's disease, and that happens in a couple of different nuclei, and they would just make a lesion. It means it means doing the surgery and then zapping, if you like, part of the brain. It could be done with heat or with chemicals, but you can imagine it's irreversible. If you get the location wrong, that's not good. And then one of the greatest advances that really came into play when I was training is this deep brain stimulation. So what deep brain stimulation does is it allows you not to zap, not to destroy a part of the brain, but to turn off the signal that's coming from that part of the brain. What it happens in effect, I mean in practice, is that the person who's going to get the stimulator surgery, when they're in the operating room, they get these little tiny, they're like micro electrodes that get tunneled down to the right part of the brain where there's an abnormal signal that's causing movement problems. And just by feeding an electrical current and electrical stimulation through that, you can kind of jam the abnormal signal that's coming out. It's a fantastic therapy, it really is, and some of my patients have gone through this. When the medicines are not working, it really has turned their life around. The downside, I would say, is that, of course, you have a battery, you have some hardware, you have these microelectrodes, and so there are aspects of that that need some special attention. But this was really an amazing advance in the field. And we're at the point now where I think the deep brain stimulation surgery has become almost, it's like a standard therapy. We used to really worry so much that we would let people go for a long time not doing well on medications before we would send them to surgery. But now we realize that the more proactive we are with this, probably the better it's going to be. So that's Dr. Caplet. And he's also been involved in some of the experimental surgeries that I'm going to speak about. So the experimental surgery, there's some new approach that some of you might have heard about on the TV or you might have seen on the internet. It's using high-intensity ultrasound. It's MRI guided. It's been used mostly for a condition called essential tremor, but they're starting to use it for Parkinson's now, and I'll show you that in a minute. Gene therapy, we were actually at Weill Cornell, just to blow our own horn for a minute. Michael Caplet was the first person, the first surgeon in the world to use gene therapy for Parkinson's disease. So he really pioneered that as an experimental therapy. And other groups have now taken what he's done and used that as a springboard to develop their own treatments for testing. All of these are experimental. And then what we're really interested in my group is the potential for using a cell-based therapy. So I'll come back to that because that has a history, and I just want to tell you what we think we can do with it. So the gene therapy, I put up some of the major examples, 3 studies that have been done, the first one at Cornell. And you remember how I said with the deep brain stimulator therapy, you'd want to get to a tiny portion of cells that were hyperactive, that were making an abnormally high signal. So what Mike did was really genius. Instead of using an electrical micro stimulator to do that, he actually made a genetic engineering of those cells that would turn off their abnormally high signal. And if anyone wants to know more about that, it's a beautiful approach, it really is. So that was the first study that ever attempted to do anything with gene therapy for Parkinson's disease. And obviously this is delivering foreign DNA into a very tiny area of the brain, so it's technically extremely demanding, but he's an amazing surgeon. It was done again with a different gene called nurturin, but actually, to my mind, the most recent, this prosavin gene therapy, again, still experimental. It combines 3 different genes. They put it in a kind of Trojan horse of a crippled viral vector and introduce it into the brain, and that's been done without any placebo control. So you can't really say how much of what they saw was placebo. But I think there's a lot of interest in the field because they did see some changes after they had used this type of gene therapy in people who were not doing that well with their medications for Parkinson's. So this extremely experimental right now, but I think we're going to be seeing more of this over the next few years. The high-intensity ultrasound, again, you're going to be hearing more about this. And it's been mostly used, again, in essential tremor. You've probably seen it on the news or on the internet. And basically what it is more or less a couple of hundred of beams of ultrasound that are distributed over the skull, over the scalp. And they beam them in, and it focuses down on one very tiny little portion of the brain. So it pretty well zaps those cells. And it's the same idea as with the deep brain stimulator or the gene therapy that Mike Caplet had used, that you want to turn off the cells that are making an abnormally high signal. So that's just been started in Parkinson's. There haven't been many reports of people going through this, but so far, the people who did report it, it seems safe, it seems feasible, and that's really, again, a huge technological advance. It's almost like getting a deep brain stimulator, but without the hardware, without the battery. And then I just want to come back in the last couple of minutes to our ideas about these cell-based therapies. So this goes back quite a few years, and actually I got interested because we have some superb collaborators over at Sloan Kettering, Memorial Sloan Kettering Cancer Center, and they have a long history of using cell-based therapies in cancer, in looking at stem cell type therapies in cancers. And so their technology for producing stem cells and working with cells that are derived, that are developed from those stem cells, their technology is really outstanding. So we've been interested in that idea for quite a few years, but we really hadn't wanted to go ahead until we were more sure and had a bit more evidence that trying to transplant cells into the brain in someone with Parkinson's to regenerate, to restore the dopamine that's been lost. We wanted to have a little bit more background before we went ahead. So let me show you the background that exists and where Natalie and I have been putting a lot of effort in recently. Back in the 1990s, this idea was very much in the forefront of people's minds. Could you use cells to restore dopamine in the brain of someone who's lost it because of Parkinson's? So, it's very intuitive. And there were a couple of big groups in the United States who said, okay, they worked out that they could do the surgery, that it was safe, and they said, let's do some testing, and they tested versus placebo, which is a very correct scientific way to proceed. This is one study. The lead investigator was Kurt Fried, and actually Stanley Fahn was the senior investigator. He's the man who mentored me and trained me. So they had just finished this when I first went for training. It's quite a while ago. And what they had done was they had transplanted cells into the brain's very small area where the dopamine signal is missing in Parkinson's disease. And when they looked at a year, they decided that really what they were going to ask the patients was, well, do you think you feel better after a year? And that didn't pan out. But when they looked at some other measures, like looking at their movement, over several years in particular, it seemed like it was improved in people who were younger who went into the surgery, not in some of the people who were older. And what I just want to show you is what they saw. I'm sorry, because I think the people at the back can't really see. What they saw after they put in these cell grafts was on the brain scans, similar to the ones that I showed you before. You could see how the dopamine signal was lost before the surgery, but then after the surgery, you could see that the dopamine signal really picks up. And so it shows that you've restored that dopamine signal. So it was encouraging in some ways, but really because it just seemed to be a subset of patients who improved, and the surgery was difficult. This whole area just got dropped for a few years. And I think that just recently, over the past 5 years, there's been a huge resurgence of interest. And a lot of the resurgence of interest is because we have these new stem cell technologies now. So it used to be, if you wanted to get tissue to transplant, the big issue is where do you get the tissue from? Human tissue is limited. Using animal tissue isn't ideal because there's a lot of issue with rejecting that immunologically. And just over the past few years, people have figured out how to take stem cells and kind of coax them along so that they can produce a particular type of cell that you might want to use in a cell therapy, a stem cell-based therapy. And my collaborators over at Sloan Kettering have really been at the forefront of this in terms of the Parkinson's world. And what they figured out and published, again, back in 2011, was that they could take these particular stem cell lines. Actually, they can take people's own individual stem cells and do the same thing with them. And they can coax them down a particular line using various factors in the medium that they grow them, using various conditions. You can coax them to become these dopamine neurons. So now we have a source of cells. And this is very much what we're working very hard on. We have a meeting with the FDA coming up in May. And we just had a meeting with other groups throughout the world who are going to be taking a similar type of approach. So groups in Japan, groups in England, groups in Sweden, groups in California who are all interested in doing this. So I think it's something that we're going to see coming up. If you have more questions about that, we'll just leave that until the Q&A session. And then the very last thing that I wanted to talk about, because we talked about a lot of kind of high science there and a lot of technology, but one of the things that I think is going to be really important in the years to come is getting Parkinson's care out of the clinic. It's like years ago, we wanted to get medical care out of the hospital and into the outpatient clinic. And now we want it out of the clinic. So what can we do? I mean, these are a few of the driving factors, I think. We do a lot of education in our clinic visits, but you don't have that long in a medical visit. And education's too important just to keep it in a very short visit. So 30 minutes, not enough. So we like to expand that. Lifestyle factors. There's a lot of things that you can do with your lifestyle that has nothing to do with me, nothing to do with the medicines that can help with Parkinson's and with healthy brain aging in general. And then from our research side, telemedicine is a great area of interest, but actually we've been interested in our group in using apps and using personal devices that we might be able to monitor people and get kind of information in the wild, if you like. So when people come into our office, we may be seeing them they're in a better state than they normally are, in a worse state. Maybe they're nervous, maybe they hate seeing me, maybe they don't look as good as normal. So we like to get a bit more information about how they are outside of the office. And this is something that Natalie's been working a lot on. It's called a personal kinetograph. It's a little bracelet. It just tracks your movements. And we've been using it to track movements over 6-day periods in a few of our patients. We're just trying it out right now. It tells me when people are slow, when they're moving too much, if they get dyskinesias, which are a medicine side effect, when they're sleeping. So actually we can look back over a week or so and we can see, are there patterns, are there times when people just aren't doing well and we need to work a bit harder on the medicine. So that's one thing. Another thing that we work very hard on is getting people into exercise. This is really important. This is the first project I ever did at Cornell. It was energy yoga for Parkinson's. Now we work with we've had a lot of fun with a dance group, but there are all sorts of exercise modalities that can be used. Things like Tai Chi, aerobic exercise, resistance training, bicycling. And so I think there are a lot of things that can really be done outside, and I'll just bring up this beautiful dance group. This is called Dance for Parkinson's Disease. This is David Leventhal, who sort of led and developed this whole idea of using dance. And if you think about it, dance makes you move. It is exercise, but it makes you think, and it makes you learn. And you've got to learn your steps, otherwise you look more like me, who can't dance to save my life. But this is really a great, great group. We did a little study over 16 sessions and we could see improvements, and there's now a much bigger study going on trying to figure out how people, who benefits the most, how they benefit, and is there a better way to do this? And that's really gone international now, so that's been great. I want to just show you what Natalie's been working on. It's a multimedia education tool. Remember I said education is too important to just leave in our half-hour visits in the office. And Natalie, and she can answer questions about this, but she's been working on, it's a tablet, a Nexus tablet, and she's devised a really lovely module about education awareness, where you can sit through some didactic sections where you learn, you read, and then there are quiz sections. It's interactive, and I mean we've all done it in our office, and it's just really great. And it says right now that she's tried this on 26 patients, but it's more than that, and she's going to be presenting the results at a big international conference this summer. The apps I mentioned, so I'm just going to finish up. And for anyone here who's my patient, they know I nag about two things. One is exercising enough, and then the other one is eating right. And there are just so many elements that go into lifestyle for healthy brain aging. And a healthy balanced diet is important, but actually we know a lot more than that now. We know the effects of the Mediterranean diet. We know particular types of food that might be beneficial in Parkinson's or in avoiding Parkinson's. So you can certainly answer questions about that. But I just wanted to highlight things like this and things like the dance and the exercise therapy. Although it doesn't seem like a big technology, it doesn't seem like it's ultra fancy, but the science behind it is completely amazing. And the scientists now are starting to understand some of the effects that these lifestyle changes can have on the brain. And not just in Parkinson's, but for all of us who are getting older. So I'm going to stop right there. I do want to say thanks to our team, our funders, our collaborators. This is Natalie right here. This was our team. We were wearing some Google glasses. We were trying to develop a treatment using Google glasses, but that'll wait. And this last slide is to remind me to say thank you to all of our patients and everyone with Parkinson's and healthy volunteers who've gotten involved in the research, because if you don't do that, it's not going to happen, basically. We're not doing research on animals and cells. We're not doing research at a bench in a test tube. We do research on real people. And for that, we have to be very grateful to people who give up their time for that. And if anyone's interested in getting into one of our studies, we have a research coordinator, Anelia Hanineva. She's very easy to track down, and she's got an email that's up there. So I'm going to leave that up there. I'll say thank you for your attention. This is really scratching the surface of a few things that are going on in the Parkinson's world. And so let's have some Q&A.